Welcome to Mind Tricks Radio, where we'll explore contemporary topics in psychology through interviewing creative and innovative thinkers in the field. I'm your host, Dr. Aaron Kaplan. Thanks for tuning in. Hey, Tyler, welcome back.
Hi, thank you. Yeah, glad to be back.
It wasn't too long ago that I saw you and we recorded our last episode about emotional reasoning. That was a ton of fun and has been really well received. And so I'm super excited to have you again to talk about today's subject, which is PTSD or post-traumatic stress disorder and differential diagnoses. So I hope you're pumped up for this one because I am.
I am.
Let's start off, first of all, the whole idea about this is to try to understand better about what PTSD is and what some of the common differential diagnoses are. In other words, other diagnoses, psychological disorders that people could have that look similar to PTSD in some ways, but are not PTSD. And I also want to start by saying that whatever Tyler and I talk about today is not meant to be used for you to diagnose yourself with PTSD or anything else. This is for informational purposes only. If anything here resonates with you, please see a clinician and have these properly diagnosed. But hopefully, from our conversation today, you'll get some ideas about these various different disorders that we find and understand some of the differences between them. So, PTSD. So, this is an interesting disorder. We find it in the Diagnostic and Statistical Manual of Mental Disorders. This is where we go to look at the symptom criteria for all sorts of different disorders that people are diagnosed with. PTSD is kind of an interesting one, especially I think it has the historical context in combat-related trauma. And even going back to World War One, this was the idea of the soldiers coming back and they were labeled with things like shell shock, in World War II, combat fatigue. And then finally, after the Vietnam War, the Department of Veterans Affairs, or the VA, started doing a very good job really looking at this condition in the vets that came back, and was a lot of more research was being done about PTSD and trauma. And it was formally included in the DSM-3, the version number 3 in 1980. And then after that, clinicians really started seeing that it's not just combat veterans that suffer from PTSD, but survivors of many other kinds of traumas as well. And then the research on PTSD started exploding after that to all sorts of different kinds of trauma. So that's sort of just a little background here. Do you have any thoughts on that, Tyler, on just sort of the historical background?
That was a nice summary of that. Yeah, and there is even some written information of the symptom presentation going all the way back to, I think, like, Roman times. There's some documentation of that, but they didn't necessarily call it PTSD back then. But yeah, that was a good summary.
An interesting thing about PTSD is it's one of the few disorders in the DSM that actually has to have an event that you need to have in order to make the diagnosis. So a traumatic event has to occur in order for you to have PTSD. And a lot of other disorders, a lot of the anxiety disorders and mood disorders and even psychotic disorders don't have that. There doesn't have to be a known antecedent event to be related to the cause. The only differences might be like a substance abuse disorder. Obviously, you have to be abusing substances to have a substance abuse disorder, or some kind of an organic brain disorder that leads to cognitive dysfunction. Aside from those, though, there are very few that actually have an event that's associated with developing PTSD. And so, what about that, Tyler? Tell us a little bit about this kind of concept of the event that needs to be there in order to have to develop PTSD.
Well, yeah, it's referred to as criterion A and in the diagnostic system. It's, exposure to something that is pretty serious, usually death related or serious injury related or sexual violence. It can be one time or it can be repeated times. It just depends on the event. That'd be the criterion A for PTSD. Yeah. Serious
Right.
stuff. Yeah.
Serious
Hmm.
stuff, yeah. And so I also, it would be worth mentioning this idea that people throw the word trauma around pretty liberally these days. Like something happened and it was traumatizing to me, and they could be talking about an argument with their boss or something like that. So when we're talking about that criterion A, an event, it really has to have created really intense feelings of fear, helplessness, or horror, where your life was at stake, your well-being was at stake, and it was just several levels above just that bad experiences that we might have on a day-to-day basis. Sexual violence, actual violence, combat, those kinds of things clearly fall into that category, right?
Right. Yeah. You bring up a good point, Aaron, in sort of the casual use of trauma or even the diagnostic term PTSD or post-traumatic stress disorder. That more and more it seems like people say things that are not, in alignment with what the A criterion would be. It's just kind of the way that society is. And I went to the mall during the holiday season and had a really hard time finding a parking space and drove around for half an hour. I'm traumatized, and oh my gosh, I have PTSD from trying to find parking space at the mall because it was so crowded. You know, it's a corny example, but I mean, people talk like this more and more, and unfortunately, that weakens the usefulness of those terms when we really need to be using them for people who really have been facing serious injury or death and these kinds of things.
Yeah, exactly, right. So, assuming that a legitimate traumatic event has occurred, and this can be a single event, right? A single bad thing happened to somebody that was really intense, or it could be ongoing events that occur that
Mhm.
are traumatic, ongoing childhood sexual abuse, for example, or ongoing domestic violence in a relationship. Like there's multiple events. So that PTSD can occur because of a single or multiple events. All of those are possible. We then have three main criteria of symptoms that need to be present in order to diagnose PTSD. So the event is there, and then there's a criterion B, and this has to do with the kinds of symptoms that we call intrusive symptoms. And there are several of them. And really, you only need to have one of these present in order to adequately meet criterion B, the intrusive symptoms of PTSD. Tell us, some examples of intrusive types of symptoms, Tyler.
You could be just sitting at home and a memory pops in your head that, related to the traumatic experience. And it's very upsetting. It just keeps coming in and it shows up at any time or certain times, and it could be very, very upsetting, unwanted memory of the trauma. It could be mowing the yard and
Just
uh,
pops in your head.
yeah, right. Yeah, right. It's just intruding into the experience in the present moment.
Right, right. So those are unwanted thoughts that pop into
Hmm.
your head. Another kind of example of that would be nightmares. You're not thinking about the event happening, but then
Hmm.
your brain sort of goes to those nightmares and wakes you up often, and those can be very intrusive and unwanted. Again, we're not sort of talking about like mildly unpleasant dreams that you didn't really like. These are dreams that are really waking you up and feeling unsettling and anxiety provoking. Oftentimes, people can wake up in cold sweats or their heart's beating really fast, which can happen. People can have nightmares even if they don't have PTSD, but that's a common symptom of a person who does have PTSD. And then there's these intrusion types of symptoms that have to do with being triggered by reminders of the event. What are some examples of that?
Well, like, you're out and about in your life, and let's say the trauma that one experienced involved a guy wearing a red shirt and he had a mustache. And if you're out and about, it could even be years later, you happen to see a different guy, but he's wearing the same kind of red shirt and he's got a similar mustache. The brain will pick up on that if it's been associated in certain ways with the trauma and becomes very distressing, very disturbing. The person may start to think the trauma, is happening again, and or they're in a lot of danger, and they're remembering what happened, and they're thinking, oh gosh, I'm in this bad situation now, and then that leads to a whole other host of behaviors which can get in the way of what they're doing in this current moment.
Right. So it could be a person, it could be a
Uh-huh.
place.
A
It could be a
thing.
sort of a thing, a situation, a song, a type
Hmm.
of food,
Hmm.
something or another that triggers that memory of the traumatic
Hmm.
event and then brings up these very uncomfortable feelings that come with that.
Hmm.
And sort of a side note, there's this idea of flashbacks, which also fall into the intrusions, and that is that the trigger and the reminder is so strong that you actually feel like you're back inside the traumatic event as if it were happening at that moment. And that's sort of like at the more extreme end of that intrusive thought type of symptom.
It's thought that true flashbacks are actually not as common as people tend to think.
Yeah,
And the word flashback associated with trauma and PTSD is also one of those terms that seems to be kind of mixed up a lot and used a lot when it's not truly a flashback. A flashback is really involving loss of touch with the current reality and believing that one is back in that moment,
yeah,
you
that's a
know.
very important distinction to make, Tyler, that when people often commonly use the word flashback, what's actually happening is they're having a memory of something
Right.
that happened before. The flashback is more than just a memory, it's actually re-experiencing the sensations inside of your body as if you were really there. And it is pretty uncommon, and I've mostly only seen that with combat veterans. You see that the flashback symptom much less commonly with other types of trauma. But that's right.
Mm.
It's very different than just like having a memory of something that happened. Then, we've got the avoidance symptoms. That's criterion C. And tell us a little bit about your kind of idea about avoidance.
Well, if a person is having these intrusive reminders coming up that we just talked about, and it's triggering up, increased heart rate, blood pressure, muscle tension, anxiety, very, very a lot of ramped up emotional and physiological symptoms, and memories, that are unpleasant, then it's kind of only natural to want to avoid that stuff. And that's what most people do. And if they're very, very strong related to a trauma, then people are going to do even more efforts to avoid. So it can be avoiding people, places, things, avoiding reminders. We often call them harmless reminders because in many cases they are harmless. They're not all harmless. I mean, if you're avoiding the actual perpetrator in a trauma, then that's, we don't count that as like avoidance. That's just prudence,
Right,
you
right.
know. But avoidance of certain memories is a very, very common thing in my practice. People who've experienced trauma, they just don't want to think about, they don't want to talk about, they try to distract themselves. They don't go to certain places or certain beaches. They don't even say certain names sometimes. Very common in my practice is people avoiding a smell, often an alcohol, a sound, often a song, and often a place. Photos, people avoid photos.
Yeah, so we could probably say that the type of thing that might be in the normal routine of a person, if they're going out of their way to not be around those things or think about or be reminded of those things, they're altering their behavior in a way that is avoidance, and that would be an example of that criterion. Yeah.
Well, that's right. That's right. And the avoidance is generally geared towards getting relief from the unpleasant things that they're experiencing is sort of the purpose of it. So the brain and the body want to avoid.
Yeah, then we have negative cognitions and mood. And I know along with that comes things like guilt, detachment, and distorted self-blame. Any thoughts on that one?
Yeah, the thing about this one that's interesting is guilt never used to be as kind of recognized in previous editions of the DSM and with PTSD and trauma, but I'm glad to see it getting more of a prominent role in understanding trauma and PTSD because I know in my practice, a lot of clients experience guilt about, what they did or didn't do related to the traumatic event or events that they experienced. And so, people often have guilt about things that they did or didn't, things that they thought that they think they, quote, shouldn't have thought. Sometimes the things that they felt that they're thinking they shouldn't have felt or could have felt something different. And the guilt ends up being a real life wrecker. And it's related to some of the other kinds of things that kind of play in kind of the detachment and the emotional numbing that tends to happen. The guilt tends to feed that. And it can turn into a very big problem over months and years. It just goes on. And then, it's tied with shame and some of these other kinds of things as well. But it's pretty common in my practice when
Yeah,
treating trauma.
Big time. I know that guilt is a huge one in trauma, and I know it's a big part of your work. You wrote a book having to do with guilt, or you co-wrote that with Dr. Edward Cubaney,
Hmm.
and so you've written a lot on that. I actually had you on my show, or my very first episode of Mind Tricks. We talked
Oh,
about,
that's right.
yeah, trauma-related guilt, and then I think I had you back on, and we talked a bit about hindsight bias, which is a big component of guilt. So yeah, guilt, big time. There's a lot of that associated with trauma and PTSD. And also this one about detachment, I just wanted to say a quick word about that. You talked about that briefly, that the detachment is sort of like this emotional numbing or pulling back from emotions in general because the emotions are so painful and so difficult oftentimes with people with PTSD that it's sort of like they shut down the emotional areas of their brain to sort of not feel anything as strongly. The problem with that emotional lever, Tyler, right, is that you can't selectively turn off emotions. It's all or nothing. So if you are pulling down that lever to not feel guilt, to not feel pain, anger, shame, those things, you're also turning off the lever for love, happiness, contentment, all the positive things. So that's where that sort of becomes a problem with PTSD. Let's talk about the next set of symptoms, the criterion, what is it, D or E? The arousal and reactivity symptoms. Let's say a
Hmm.
few words about those.
Common in trauma, right? Hypervigilance, irritability, increased anger, ramped up general presentation, difficulty sleeping, a lot of stuff that's just kind of, more ramped up than would be healthy to be moving through life. Sometimes I think of it as like a car that's in neutral and there's a brick on the accelerator.
Yeah.
And the car says, it's kind of going through life like that. You come up to a stoplight and put it in neutral, but don't move your foot off the accelerator. It's just ramped up. It ends up causing problems for people. It will wear them out physically. It'll cause relationship problems for them. They're not to blame. It's just kind of how this works with trauma. Depending on the trauma, depending on the person, can present a little different. So, for example, when I used to work a lot with male veterans, there was a lot more outward expression of irritability and anger in the form of aggression. And when I work for many, many years now, 2 decades with formerly battered women, it's a little subtler to see. Their hypervigilance is there and easy to see, but the kind of the irritability and anger shows up a bit more as sort of what we'd call like a cynically hostile
Hmm.
worldview, a little more cynicism. That sort of. Sometimes it's real, outward aggression and stuff, but and then there's commonly sleep issues as well.
Right. Well, that sort of internal thermostat that's set at a higher level obviously leads to the concentration problems, sleep problems, irritability, some of those things you talked about. The hypervigilance is kind of an interesting one. Like with hypervigilance, let me try to explain. It's sort of like this idea of like walking through life and experiencing things and just having, your eyes on the side of your head, scanning all the time for things around you, orienting yourself in the world around you, being very cautious and aware of stuff going on so that you can't be taken by surprise and harmed in some way. And that maintains a certain level of energy and attention and focus to do that. It's very draining on people to be constantly hyper vigilant. And I know you've probably seen plenty of vets who say, like, well, I go into a restaurant, I scan everybody and everything before I sit down. I pick a seat where I can see everything in the restaurant at all times, and my guard is up because I'm in this crowded place that I don't feel safe. So I think it's like that with other forms of trauma as well, but that's sort of the hypervigilance piece. Does that sound
Right.
accurate?
Yeah, right. I work with a lot of formerly battered women and, checking doors and windows at night and making sure things are locked and, a lot of this kind of behavior, really scanning the parking lot if they go to a mall or go somewhere, scanning the parking lot before they get out of their car. And
Okay, so like those are the main clusters of symptoms, and you have to have a certain number of those within each one of those criterion in order to meet criteria for PTSD. And we don't have to spend a lot of time on the specifics around that right now, but a couple of other things that are really important for diagnosing PTSD is these symptoms have to be present at a great enough level to meet criteria for more than 1 month. That's important. So they have to persist for more than 1 month after the trauma in order for you to meet criteria for the diagnosis. Also, the symptoms, even if they're there, they have to cause you significant distress or impairment. So just having the presence of some of these symptoms, knowing that there, I might have memories of the trauma occurring. I might have some triggered experience when I'm reminded of them, but they have to cause clinically significant distress when I have them or impairment to my life in some way. So that's also important.
I have a question about that. How do you look at that significant distress in your practice?
I think I just try to, for whether it's clinically significant distress, I determine whether or not it's bothering them enough that it's worth mentioning and talking about it and wanting it to bother them less. That's how I do it. I mean, it's very subjective in that sense. But if somebody says that it's bothering them to the point that they don't like it being there, to me, that's clinically significant. Whereas oftentimes I'll talk to patients and they'll say, yeah, I'm having these memories and it comes up from time to time. And every now and then I have a nightmare or something. And I'll say, well, how much does it bother you? It doesn't really bother me that much. I mean, like, I don't particularly like it, but I just take note it's there and it doesn't really affect me in any way. And then similarly with the impairment, like if somebody says they're having a memory or an experience, they're having one of these symptoms, and they don't like the impact that it's having on their life in any way, I would consider that clinically significant impairment. So I don't really have any kind of like a numerical measure of it. It's more the subjective experience of the person for me to determine whether or not it's significant distress and it's causing significant impairment. What do you think?
Yeah, yeah. I do the same, and I sometimes will just ask myself, hey, do you think this is significantly, if this distress is significantly affecting your life? Ask them in their words. I also think that the distress is closely tied with the impairment, because if they're so distressed that they're impaired in work, in relationships, maybe they're in school, maybe in just day-to-day stuff, then that gives us a window into their level of distress also.
Right. Well, the distress and impairment usually go hand in hand. That's right.
Yeah, but you're right. I would agree. There's a subjective level to that. We have instruments to measure things, which I know we can talk about later. But they'll say, oh, if it's rated at this level, then okay, we'll count that as counting or significant enough. But there's a lot of gray area in it. It's important to talk to, like you said earlier, talk to a professional about some of these kinds of things. You get a
Yeah.
second opinion. Yeah.
Yeah, for sure. And the last thing I want to mention about PTSD is that the symptoms that one is experiencing is not due to the use of substances or a medical condition, because substances can cause people to have internal experiences or to feel certain ways, can alter your physiological and emotional state, and so can medical conditions. So, in this particular case, PTSD is the symptoms are caused by the traumatic event or experiences, not by anything else, including the effects of substance use or medical conditions.
That's right.
So let's get into differential diagnosis a little bit. And I have several here I want to talk about. And these are all disorders that are found in the DSM manual. And we can talk a little bit about how they're similar and how they're different. And I think it would be kind of an interesting exercise to go through that. So the first one and the most sort of obvious one is called acute stress disorder. And there's similarities to PTSD. Tyler, why don't you explain this one?
When we're looking at differential diagnosis, in other words, things that might look like PTSD but are not, and we want to learn to differentiate them as we're diagnosing. Acute stress disorder is one that comes up commonly, and the symptoms are similar when we look at PTSD and acute stress disorder. But the main difference is acute stress disorder is, like the name implies, shorter in duration. So the cutoff is basically within 1 month of the trauma. Once we go beyond that, then we're looking at it being more like PTSD. And acute stress disorder, if it doesn't go away on its own, or if a person doesn't get help for it within that 1 month times, it often is a precursor that turns into basically a diagnosis of PTSD.
Yeah, exactly. That's right. And I think it's important to point out that having symptoms that would meet criteria for acute stress disorder are very, very common following a traumatic event. So, in other words, within the first month after that happening, a very high percentage of people may meet that criteria right afterwards. And then you see the symptoms just sort of improving and abating, and oftentimes they're no longer present after a month. And so the person then would not make it to a PTSD diagnosis. So that doesn't mean if one has acute distress disorder, it's still very helpful to reach out for help and get help for that. Sometimes they just relieve on their own, but also just getting help immediately can help it not turn into PTSD. And so that's important. The next one I want to talk about is adjustment disorder. And I haven't read the research literature on this. I would guess that this is probably the most commonly diagnosed disorder by clinicians across the board. Usually they need to come up with some kind of a diagnosis for the insurance companies in order to be able to bill for the services. And it's probably usually this one is the most common one. And an adjustment disorder usually has to do with adjusting to something happening in one's life that is causing them to feel the way they're feeling. And you want to take it from there, Tyler? Say a few words about
Yeah,
this.
yeah, I agree with what you're saying. It's really a common thing for people to experience. It's commonly diagnosed. It's related to, all kinds of things in life. When we think of adjustment disorder and PTSD in terms of differential diagnosis, one way we can look at that is adjustment disorder. Somebody could experience the same criterion A, PTSD, traumatic event, but not necessarily have enough in the other PTSD symptoms to count as a diagnosis of PTSD. So we'd often go, okay, they're upset or they have some of the symptoms, but not enough, and we can say this is adjustment disorder. The opposite is also true in that they might have a fair amount of the PTSD-like symptoms, but there's no clinical significant level criterion A going on or that they've experienced. And so we'd say, okay, this looks more like adjustment disorder, and sometimes it's sort of like, a divorce or maybe they lost a job. So when we look at those kinds of things, they can be really, really upsetting and a person can have symptoms related to them, but they don't meet PTSD criterion A, severe injury, loss of life, witnessing loss of life, these kinds of things. And so it's an interesting when we consider differential diagnosis and in some ways it kind of ends up being a little bit of a catch-all for some diagnoses.
I agree, right. So it's often the person is having a hard time in life for some reason. It's not at the level of PTSD. There usually isn't a traumatic event involved, but there's an ongoing divorce. There's having problems with my child. That's very upsetting for me. Work situation is sort of unbearable because I have this really toxic boss or something like that. And it's really, really hard, and the person is just struggling dealing with it. And they may experience symptoms of anxiety or depressed mood. And actually, with adjustment disorder, you can have adjustment disorder with anxiety, adjustment disorder with depressed mood, or both. But that's what adjustment disorder is. It's sort of a bit of a lower level of anxiety when we're comparing it to PTSD.
I would add that adjustment disorder, in my opinion, is one of the more commonly misdiagnosed. Well, I'm confused with PTSD among people that are experiencing difficulty. Oh,
Yeah,
I've got this symptom, I've got this symptom, oh, I must have PTSD. Or they experienced the criterion event, the A event, the trauma, but they don't necessarily meet the other criteria. But they're like, oh gosh, I've got, PTSD. It's probably more like adjustment disorder in that case. Yeah.
good point. Let's talk a little bit about generalized anxiety disorder, or GAD. This is pretty commonly diagnosed, actually. And with generalized anxiety disorder, what we're typically looking at is sort of like chronic, free-floating worry across multiple domains and not necessarily tied to a traumatic cue. And they may have physiological tension, they may feel restless, they may have sleep problems, oftentimes related to the anxiety or the worry that they feel. But in my experience, Tyler, and I'd like to hear your thoughts about it too, but I sort of see this as just like chronic worriers, people who are constantly worrying about not even just one thing, but lots of things in their life, and worrying to the extent that it's really causing them significant distress and impairment. It's really giving them a hard time. What do you think?
Yeah, I agree. Yeah, I tend to think of GAD, generalized anxiety disorder, as kind of a shallower, broader kind of a presentation. Not to, I don't mean shallow in that what they're experiencing is not meaningful to them or bothersome to them. I just mean that it's kind of, it could be this anxiety and worry about a whole variety of things. Whereas PTSD usually tends to be a narrower, deeper kind of a experience in the sense that there's a traumatic event. A lot of their symptoms are just tied with that, and we see them pretty strong in the
Yeah.
symptoms. It's interesting. In my practice, when somebody may have before a traumatic event met criteria for GAD, generalized anxiety disorder, and they've got sort of that presentation going on, and then they experience a trauma in their life, and then they come in to get help, is sometimes it can be a little bit of a thing to kind of tease out how much of this is related to the PTSD and the traumatic event, and how much of this was sort of pre-existing worry about a whole variety of things, you know?
Yeah, I agree. And also, this is an important point that a lot of these disorders can be comorbid. So you could have both at the same time. But I think oftentimes they're overdiagnosed as comorbid, and we can usually find one that sort of supersedes the other anxiety disorders. The thing I want to say about generalized anxiety disorder, though, before we move on, Tyler, is a lot of people worry. They worry about things and they call themselves worriers. And I think GAD can be overdiagnosed just for people who tend to worry a lot. For me, in order to get to that level of GAD, not only are you worrying very irrationally, usually, about a lot of different domains of your life, but it's really causing you so much anxiety that it's impairing. So I want to make that point here.
Good point. Yeah, totally agree.
Yeah. So the next one I know is super interesting, and you and I both deal with this a lot in our practices, and that is panic disorder and agoraphobia. And oftentimes you have panic disorder with agoraphobia. Do you want to talk a little bit about, well, let's just talk about panic disorder first and panic attacks.
Sure.
Let's talk about what that is.
Yeah, sure. In panic, the focus is generally more of a fear of the experience of the panic and the symptoms themselves. It can be the anxiety itself or even the physiological symptoms. Panic's focus is not necessarily about a traumatic event.
Right. People have panic attacks. They're terrified of having the panic attacks. And then the panic attacks are exacerbated because of the fear of having the panic attack. They're terrifying. And if you've never had a panic attack before, be happy you haven't. And if you have had a panic attack, I'm very sorry. They're really no fun to have. But the
Right.
panic disorder becomes about having panic attacks and being afraid of having the panic attacks. And people with PTSD can have panic attacks, right? But
Right.
usually those panic attacks are triggered by something within the PTSD paradigm and not because of the panic attacks in and of themselves. Would you,
That's
would
right.
that be correct?
Yeah, I agree with that. Yeah, yeah, that's right. Fear and panic becomes how can I not have this experience that I'm having rather than in PTSD? How can I not be around this smell or this song or this reminder of the trauma?
Right. The panic attacks are associated directly with something that has to do with the traumatic experience. So then we have agoraphobia. A person can have agoraphobia with or without panic attacks. In my practice, usually people with agoraphobia have panic attacks sometimes, but I have seen people with agoraphobia who claim they've never had a panic attack before. People often think about agoraphobia as like the person who can't leave the house. because going outside is so anxiety provoking for them. But really, the definition is a lot broader than that. And I see a lot of things like subsumed under agoraphobia, like claustrophobia to me is sort of a category of agoraphobia. It's all about the fear of being able to escape from situations that feel really uncomfortable. And so people are trying to avoid them because of the anxiety that they're anticipating feeling while they're in the middle of doing them. And so this could be being in crowds, it could be in a crowded shopping mall, it could be on an airplane, it could be riding a
It could be
bus.
far away from a lot of people even. The
Yeah,
further I go out of town into the desert or the mountains driving or whatever, I won't be able to get help if I need it. I won't be able to escape this situation, get the help if I need it.
right, right. So those situations are very anxiety provoking to people. And so they try to avoid them. And when they go into them, they tend to feel anxious. So differential wise, how is this different from PTSD?
Well, PTSD, the focus is on avoiding the trauma reminders, what we call the things that are scary but not necessarily dangerous. Whereas in agoraphobia, it's like the avoidance is around, I don't want to have this experience, these panic-like symptoms, and I don't want to get embarrassed. I don't want people to see me panicking like this. I don't want to have these feelings come up and stuff, rather than PTSD again, is more like almost PTSD is often these external things like trauma reminders, a smell, a place, a person, a sound.
Yeah, that's a really good point. I think with agoraphobia, just to kind of recap what you said there, most of the time, the things that are being avoided by the person who has agoraphobia are things that that person would typically say these are not inherently dangerous things,
Mm,
but still, when I'm there, I feel anxious. The perfect example is like going into Costco or Walmart or something. Most people would say, no, those places are safe. I'm not going to have any harm come to me if I'm there. But those situations just being crowded out by a lot of people and everybody's looking at you and bumping into you, I just feel suffocated in there. It's anxiety provoking, and I just want to get the hell out of there as fast as I can, and I don't want to go. So that maybe is what you're saying is a little different than PTSD, where it's avoidance of things that really did remind you of something that was dangerous or scary in the past.
right,
Then when we add the panic attacks to it, so panic disorder with agoraphobia, it sort of compounds it because people who are in these situations that are anxiety provoking for them and then have panic attacks in those situations, not only is it anxiety provoking, but they want to avoid because the last thing they want is to have a panic attack while they're there because A, they feel like I might pass out, something bad might happen to me while I'm having a panic attack. It'll be embarrassing. I might hurt myself, and then what I'm going to do laying there on the ground. And by the way, most people don't have panic attacks and fall to the ground and become unconscious. That's pretty rare. But it's that fear of like, what's going to happen to me if I have a panic attack in this situation, right?
right. That's right.
Let's talk about OCD or obsessive compulsive disorder. This is another anxiety disorder. It's classified as an anxiety disorder. And with OCD, we also have this concept of intrusive thoughts that come in, right? We talk with PTSD, there's intrusive thoughts that people have. With OCD, there's also intrusive thoughts. And this kind of ruminating that takes place with OCD that's very, very uncomfortable, and maybe even an avoidance of things that have to do with the OCD fears that take place. And OCD, by the way, is very common. And if you're interested, I've done a few episodes of Mind Tricks Radio about OCD because it's very common and important. But here, Tyler, let's talk a little bit differentially how OCD is different from PTSD. How do you differentiate
Yeah.
the two?
Well, one of the biggies that I always am looking at when I'm working with somebody or beginning to work with somebody is, is there that criterion A? Is there a traumatic event? And with OCD, even though they have intrusive thoughts that are going on for them, it's really not related to any, there's not a traumatic event in OCD. That's the big difference with that, you know. People with OCD have a fair amount of compulsions usually, and PTSD, we don't usually see the really clear, obvious compulsion kind of presentation. And then, of course, with OCD, they often don't even have the other PTSD symptoms. So the intrusive thoughts can look similar sometimes, but a lot of the rest of the stuff doesn't look that similar, actually.
Yeah, right. Well, I see the intrusive thoughts that come with OCD as extremely irrational. You know, people could have an intrusive thought that, like, I'm going to reach over and start choking this person, or I'm going to walk down the street and suddenly not be able to prevent myself from singing at the top of my lungs and making a fool out of myself, or I'm driving the car and I think I might have accidentally ran over a dog, and then they go back again and again to see if they did, and of course they didn't.
That's right.
So oftentimes the intrusive thoughts are pretty fantastical and don't make a lot of sense. And they're ego dystonic, which means they don't feel like consistent with what's actually really going on. They bother people. And I should also say you're right about the compulsive part. We don't usually see compulsions with PTSD, but with OCD, people engage in compulsive behaviors to sort of undo the intrusive, anxiety provoking thought that they have. I start thinking I might reach over and choke this person. And if I knock 3 times with my left hand and my right hand on the table, I won't do it.
Right.
So
Yeah,
that would
right.
be
It just
like,
doesn't even make sense. But yeah, right.
doesn't make sense, but that's what happened. So it's a completely separate animal then from PTSD because it's not related to any trauma, any intrusive thoughts that have to do with a traumatic experience. And then you have the kind of odd compulsive component to it. Getting away from the anxiety disorders a little bit, obviously there's a big mood component to PTSD, especially when we were talking about some of those negative cognitions and mood symptoms that go along with PTSD. So, how would you differentiate PTSD with those negative mood symptoms that come along with it, with, say, a mood disorder such as major depressive disorder or even some other
Yeah.
form of depression?
A big difference is that in mood disorders, we often don't see the prominence of the re-experiencing or especially the hyperarousal symptoms tied to a trauma cue. It sort of doesn't have a trigger-based pattern to it. It's kind of just this thing that goes on even, just whenever. Whereas in PTSD and trauma, we see more like when the person's exposed to these things or when they have these certain thoughts, there's things that are kind of triggering. It's more tied to things related to a specific trauma.
So people can, if they have major depressive disorder or another kind of depressive disorder, they could feel hopelessness, anhedonia, fatigue, even guilt. Like we talked, guilt is a big component of PTSD, but you could feel all of these things with a depressive disorder. But like you said, you're not re-experiencing feeling hyperarousal over symptoms related to the trauma. And it's just strictly about mood and depressive thinking and not about the trauma itself. And one thing, like I'm guessing you probably see this, is actually there's a very high comorbidity between PTSD and, say, major depressive disorder, which makes a lot of sense. If somebody has severe PTSD, it's very likely that they're also going to meet criteria for major depressive disorder as well. So they're very commonly experienced, and oftentimes even like the medications are, there's a big overlap between them in terms of treating. So there's a lot of overlap in the way, they kind of go together in terms of treatment. Yeah, any other thoughts on that?
That helplessness and hopelessness that tends to come with mood disorders like major depressive disorder makes sense if somebody's struggling with PTSD and trauma symptoms and has been through a trauma. Some of the studies showed the comorbidities in the range of about 75%. If you take 100 people with PTSD, about 75 of them in some populations are going to also have a major depressive disorder.
Yeah.
So they just tend to go hand in hand pretty prominently, like you were saying.
So, Tyler, when you're going through this process of diagnosing somebody with PTSD and you're looking at these various different differential diagnoses, how do you go about it? Or what are some of the tools that you use to sort of sort this out?
Well, there's a variety of good tools in my practice. While I have a lot of experience in the past with using the CAPS, which is the clinician administered PTSD scale, and it's sort of like the gold standard. It's widely studied, it's widely known to be a really good instrument. I've used that a ton in the past. These days, I don't rely on that as much. The main thing that I'm doing is meeting with the person, observing them, looking at how they're behaving, looking at their affective presentation, listening to the actual words they're saying, putting that all together. And then, of course, using some screening tools. Like I use the PCL-5, which is the post-traumatic disorder checklist. I use that and coupled with any of the trauma surveys, like about, what kinds of traumas a person experienced. The one that I use a lot is the potentially traumatic events questionnaire. And then I couple that with the PCL. And then when I put all that together with my observance of them in the first session or two, we're usually pretty clear if somebody's experiencing PTSD or not. And in that process, I'm going through those things we just talked about with a differential diagnosis and, kind of weeding some of that out. I think of differential diagnosis when we're sorting it out, it's kind of like a Venn diagram.
Hmm.
If we've got PTSD as this circle, and we've got OCD as this circle, where are they overlapping and where are they not overlapping? And the not overlaps can tell you a lot about what the diagnosis is. Because if you've got the non-overlapping part of PTSD and it's enough of the stuff, it's not going to be OCD. And that's a way that I think about it. I don't know if that's a little too vague or confusing in visualizing that, but it's like where is something coming together and where is something different and how can we sort this out? So yeah, I'm using mostly an interview, a history and an interview in the first session or two, and then some written tools like PCLN, some of these things,
Right. Yeah.
PCL5.
Yeah,
Yeah.
that's pretty much my approach as well. I mean, it's just a good interview, taking a look at these differential diagnoses and just seeing where is the source of the anxiety coming from and trying to put them together. The PCL is a really nice instrument as a screening tool to just get some data. I really like
Mhm.
the CAPS. I mean, that is the gold standard, and you and I were both trained on that at the Pacific Center for PTSD back in the day. And I typically use the CAPS if the stakes are higher about making sure the diagnosis is correct. If I were to do a forensic evaluation, for example, and I do a fair number of those, I won't give a PTSD diagnosis without administering the CAPS because I need to make sure that this is very, very well documented. But just for clinical purposes, I think the interview and the PCL type of tool is very useful for being able to figure out, is there a clinically significant issue going on here with trauma that is worth treating?
I might also add that I don't know if this is true for you as well in your practice or your career, but 20, 25 years ago, there was sort of a more manual kind of a way of going about it. But after treating so much PTSD and formally diagnosing so much PTSD with the CAPS and stuff over the years, you get just more experienced in reading the subtleties and what's going on for a person when they're just right in front of you.
Yeah.
And not to say that there can't be great error in that, and there's studies on that that show there's great error, but you do get better at what you're doing over time, or at least that's what I've noticed in my practice, such that if I do use a more formal instrument like a CAPS or something, then it's like, okay, it's confirmation, you know.
Yeah, of course. That makes perfect sense. So, just sort of getting to the end of this here, like we're talking about diagnosing PTSD, which we've talked about a bit today, and we've talked about the various differential diagnoses. And while this might sound like a bit of a silly question, really, why does this all matter? Like, why do we want to nitpick at these various different diagnoses when we're spending our time talking about differentials?
Well, yeah, good question. As you and I both know, it matters because it guides what the treatment then will be that follows. We don't want to be applying a treatment that is not the right treatment for the person. There might be some overlap with the treatment that we pick, but we really want to try to get as clear about what's going on for the person as possible and ultimately have a correct diagnosis, so that they can be treated with the proper treatment, whether it's by us or whether they get referred or somebody else is looking at their charts, in a clinic setting or a medical setting so that it's accurate. and really guides treatment, and then based on that, there's like a number of different treatments, right? A lot of the treatments have a similar active ingredient in them, and they're just sort of different on the more or less the surface level, but there are different treatments and common ones, we'd want to know, okay, is this PTSD? We don't want to be using a PTSD treatment for something that's not really PTSD, you know?
Right, I agree. There's a lot of overlap when we're talking about, for example, cognitive behavioral therapy. It's not some magic thing that is vastly different for one to the other, but the way that we target and orient the techniques that we're using could vary depending on the nature of which disorder we're talking about here, right? So,
That's
yeah,
right.
so I agree with that.
I find with the different diagnoses, PTSD and some of the others, that at their core, there's a lot of the same mechanisms. But as we get further out from the core, we start to get those differences, and that's where having the different treatments and an accurate diagnosis is really critical.
Yeah, for sure. Hey, Tyler, this has been really fun talking all things PTSD and differential diagnosis with you. Thanks so much for coming on and talking with me today. And hopefully, we will reconvene soon with another exciting and interesting topic.
Thanks for having me. It's always a pleasure.
Thank you for listening to Mindtricks Radio. I hope you have enjoyed the program. For more information about Mindtricks, you can go to my website, www.waikikihealth.com. Be sure to subscribe to Mindtricks on your preferred podcasting host to be notified of new episodes of Mindtricks. Please take some time to give Mindtricks a good rating and review wherever you are listening. It really helps get the word out to new listeners. And please like and share Mindtricks posts on Twitter and Facebook by following your host, Dr. Aaron Kaplan.